Stop me if there are questions. I fear that this particular topic that every prescriber knows, but I'm going to walk through it anyway because I'm not sure I've ever had anybody give me a talk on OARRS. So maybe there'll be something to it that will be helpful to
I'm excited
everybody.
Because I don't get to see, as a counselor, I don't get to get into this. So I have to talk about it, and this is the first
No, I mean, I think it's good overall, but I've never had someone give me a talk. So I mean, that's, in that respect, it's nice.
Yeah.
So to sort of see what is this. So OARRS is the acronym for the Ohio Automated Prescription Reporting System. And really this came out of the opiate epidemic and the pill mill bills. So there was a period of time, I think we're talking 2010, 11, 12, when there were issues with, quite frankly, they were unscrupulous physicians. Most of them were anesthesiologists, as I learned from the police, who had set up shop, and they were in the guise of pain specialty clinics. And what they were actually doing is they were cash for prescriptions for opiates and other things. We had this happen in Lake County up in Paynesville, where I see my workers' comp patients. And one of the officers told me that they had trouble with people coming from lots of places. So we had their ADM board director run a report. She couldn't give me names, but she got me zip codes. There were people driving all the way from Florida to see the pill mill doctors, because they would basically go, 4 people would come in one car. They would each see the doctor for, I suspect, about as long as it took to write prescriptions. The doctor was documenting low back pain with no evaluation, no exam, anything else. Would give them a 3 months, these are prescriptions, not the actual pills, 3 months prescription for Percocet or the like, 3 months for Tramadol, 3 months for Xanax. And then they would take their rather large ultimate supplies, drive to Florida, sell them for a lot more than the $300 or so the doctor got per person. So probably did all 4 people in about 15 minutes. That's a pretty good $1,200 an hour. That's half of what they pay most of us here at Neomed. So that's a pretty high amount. And so they were getting all their monies. And of course, they made a lot of money. The doctor made a lot of money. And so eventually it got coined pill mill. And thankfully, eventually the legislature went after that with the pill mill bill. And with that, the issue of doctor shopping was what needed to be addressed. That was the worst criminal side. And they did actually ultimately go after many of those doctors criminally and shut them down and so forth. Which unfortunately had some side effect, which is some people had to go find their own opiates, which meant heroin on the street. So there's a negative to every positive, but we had to get rid of that. It was just a travesty to have that going on, and in a lot of ways just soils the reputation of all the good clinicians. They're trying to help people, and you got these people cranking out prescriptions for personal gain. So OARRS, really, this concept came out. I think a lot of it came out of the opiate epidemic, and maybe all of it. And it's spread to all the states. So Ohio is not first. We also were far from the last. And I'll show you a screen that shows a lot of the states you can click on, because they work across states now. So you can actually check to see if your patient. So for example, I have patients in Youngstown, and a couple of them actually have Pennsylvania addresses. So they very well may get prescriptions filled in another state. And if I only check the Ohio OARRS report, I may miss their doctor shopping, 20 miles away kind of thing. So anyway, so I have no disclosures for this. I'm going to basically use the OARRS support manual with a few other slides as a sense. So you can definitely get more detail if you would like by going to this State of Ohio website and pulling up the Ohio AWARE RX, if you will, manual. So that was a pretty nice way to do it. So who can use this? And they call these people requesters. So any of us in the room that are prescribers are probably already using it, because by law we're supposed to be. So I won't ask anybody who's not using it to say that. They're a prescriber. But so if you're a requester, it initially takes a process of signing up. They need to verify that you are who you are. So, NPI numbers and DEA numbers and your weight at birth, all that kind of stuff. That was a joke. But anyway, so you had to do all this stuff to sign up. And obviously, you know, what we don't think about is who else might prescribe controlled substances. And this was, you know, even in me as I prepared this, it's true. You don't really think about optometrists, you know, might give something for eye pain if somebody got an eye injury. I do think of dentists because they're often pop up for other purposes. They have a high death by suicide rate. They obviously prescribe pain medications for various tooth pain, wisdom teeth removal being probably the biggest, maybe root canals, things of that nature. Veterinarians also fall on here, so they do actually, of course, prescribe high heavy-duty medications at times, and sadly, they also have a high death by suicide rate. There may be a correlation here somebody needs to do a study on. Podiatrists who actually fall under the same state medical board as physicians. So it's actually physicians and podiatrists in that board. So all the people that might do it. And then you'll notice, and I think this is really key, and many prescribers don't know this, that there are administrations that are able to look at these reports. And then, of course, law enforcement's able to go in there. And why is that important? Well, they could go in and look at Dr. Jones' prescribing, and based on that, probably determine that he or she is a pill mill. Right? So this was not just created to prevent doctor shopping from the individual clinician point of view. It's also created so that the government and law enforcement can stop people from being pill mills. Because again, it came out of that, so I gave that background.
But do they not have to have a warrant for that? Can they just randomly, like, let's say you get pulled over because you're speeding, and then that officer, can he then just go look into OARRS and see your prescribing?
No. So my understanding is that's not how they would do it. Somebody would say, look, we've got a lot of complaints about Dr. Jones. I'll just say Lake County. And they would then get warrants of some sort, and then they would already be able to go into OARRS and run reports. So you're right about that. I don't think it's a free-for-all by any means. And I don't think it means that they're just kind of occasionally running a report to see, you know, hey, let me see. Oh, the report says these 8 doctors are the problem. I doubt they're doing it at that level now. I think in the beginning they probably did. Actually, I think the law was allowing them to look for those individuals because it's a great electronic database to do that. You'll notice at the bottom there, the Board of Pharmacy can use this for their investigations. They may very well see complaints, which may very well come through the pharmacies. And I'll show you how that shows up on the report here. And then workers' compensation. So again, with my job, I was aware workers' comp would be reviewing this stuff on a regular basis. For a psychiatrist, that usually meant Ambien or something like that. I wasn't giving out any opiates. But there are pain specialists that workers' comp requires for these patients to see. They would, of course, be using a lot of medications that show up on OARRS and the like. And they've added some over time. When they discover new drugs of abuse or misuse, I guess you would call it nowadays, like Neurontin, for example. So Neurontin, actually way back when I used to moonlight in the prison setting, they issued a decree within the prison setting that psychiatrists could no longer use Neurontin for patients, which sometimes was being used as a mood stabilizer. They would allow it only by a neurologist, which meant it had to be a consultant who came in, a specialist, only for proven seizure disorders. And that limited it greatly in this case. And the reason they did that is that the inmates, very creative, they have a lot of free time, were crushing and snorting Neurontin and getting some kind of a change of mental state from the Neurontin. I mean, nobody ever expected that would happen. They learned it, they did it. And so it turns out not only prison inmates do that. So it took many years later, until very much more recently, the last few years, they added Neurontin then to OARRS. So it's not a controlled substance, but it is now because it shows up in it. So we can also see is somebody doctor shopping for Neurontin. They have, by the way, added medical marijuana to OARRS. So you can see that if you have a patient who's getting medical marijuana. And they could do this for lots of things. Tramadol, originally not really classified as an opiate, that got added to the report. So they have the ability to add new substances if people start to use them or misuse them in a potentially addictive fashion. They can do that. So I like that. Truthfully, as I go through this, I'll tell you, I'll just say my bias now. I think this is a great tool. And what I really wish was it showed every prescription everybody ever got, because it would save a lot of possible drug interactions. You could have OARRS actually run a drug interaction for you. Pharmacies already do that. I do that on the Medscape app. when I see patients. And I actually every time ask if they've had anybody else prescribe meds, and I'll put them in as well, because my discovery has been that many physicians won't do that. And I feel like it'd be nice if a centralized place did that for everybody. It would just help. It would help all of us, right? We all go get medications, so I don't want to.
Even a person who shows up like in a psychiatric emergency and you want to figure out what med to give them, if you had a history in one place, you would know. Well, don't bother trying Haldol. That never works.
Right. Look, they actually took it for 6 months, and here they are anyway. Right. Yeah. Exactly. So, or at least they filled it. You don't know if they took it. But,
right.
So this is just another way of looking at the full list of all the people that could, in fact, obtain access to the OARRS report. Many of whom are required. The registration site, again, I already said most of this. They want your DEA, they want your NPI, they want to have addresses and dates of birth, and they really want a lot of detail. Which, when I first signed up, which was several years before they required doctors to do it, because again, I knew my workers' comp patients mostly were taking opiates. I wanted to make sure I had access right away. It seemed a little daunting. I think they've made that process a little more user-friendly, but at the time, it really did feel like I was going to wait for them to, ask me to give a blood test and a hair sample and things like that just to get access. At the time, it seemed really daunting. So when you first log into the website, this is what you see. You'll see any alerts. So alerts would be that some other pharmacy or prescriber has noted something untoward going on with the patient, doctor shopping and so forth. So you would get an alert to that effect. I believe pharmacies can send alerts to that as well. If for example, a generic drug were to come out and be tainted with something negative, they could potentially put an alert on the system so that if you went in, you'd see, the current version of Vicodin, generic, is going to cause other problems. Kind of thing. So that's important, obviously. You'll see your most recent patient request. This is the same name over and over again, but normally when I go in, again, I was only seeing patients once a week, so I would go in and see the list of people that I had seen the week before. Would basically all show up as my most recent requests for an OARRS report. In the beginning, there were all sorts of weird rules. You couldn't print the report and put it in the medical record, and I believe they've now gotten rid of all that. It made no sense. So why can't the OARRS report be part? You're checking it, so you're able to do it. There's really kind of no purpose to it anymore because it's all electronic anyway, and most people are in electronic health records. And printing a report doesn't do you a lot of good if you're an electronic health record. My belief is that Epic is, and maybe others, are tied to OARRS now, so that within the bigger gold standard, if anybody here use Epic or any electronic record that has OARRS built in?
Not for us.
Yes, I use Athena.
Okay.
But the problem is that it only checks for Ohio. So we have to go on the OARRS website to add Michigan and Pennsylvania.
Right, especially being in Warren, for sure, Pennsylvania, yeah. Thank you. So it takes a goddess to actually have this embedded, apparently, Athena, you said. So anyway, okay, so then here's what a patient requests. So then I say I'm working with Mr. Jones. I'm going to consider giving, I'll just keep using Ambien, which is a controlled substance, for the first of that classification of sleep medications that came out in 1994, I believe, when I first started to use it. I think that's when it came out. So you basically what you have to put, and you could put more in, you have to put a first and a last name, you have to put the date of birth, and then you have to put the zip code. And what's nice about this is it will, any address that the person has ever gotten medications at, any of those zip codes will work. So, because you have patients move, and if you don't know they moved, if you were tied to that zip code, you'd be in trouble because they might have moved. And now, if they're not sitting in front of you, you can't say, well, Mr. Jones, what's your new zip code? Right. So thankfully, I never had that problem, even though I know I had patients who moved. As long as I had one of the zip codes in I think it's the 10 years window, it'll still pull them up. And again, it's very persnickety that way. If you mistype any digit anywhere, it's going to tell you it can't find them. So it doesn't have any artificial intelligence built in. Maybe someday it will, but you don't have to type their whole street address, for example. You need to just put the zip code in. So as long as you do that, and then at the bottom you can see, you can click the buttons. This doesn't show them all because it would have been a really tiny slide, but it stops, I think, at the P's. If you can, I can't see it here with our screen, but I think it stops at the P's. So it goes all the way. So you can go any of the states that have, and there are just two, I think, that don't. Virtually every other state now has a version of the OARRS for each of their states. And most of them are tied to this this national database now. So if you can have, so you might have a patient who lives half of a year, I'm sure the winter half in Florida, and the other half of the year in Ohio. And so knowing that, you would want to always be checking both of those because there's a high chance. I suppose if you were really concerned, you could click select all on there. I never did that. That seemed a bit much. For my practices, if they were going anywhere other than Ohio or Pennsylvania, it would have been really strange. They'd have to really be going out of their way. So I didn't go that far. And you're not required to. You're required to check your state. In some cases, like Pedro said, it makes sense to check Pennsylvania if you're near it, and maybe even Indiana, because those are the two closest that we see.
Would city and state work if you didn't have the zip code?
I don't honestly know, though. That's a good question. I never tried that. So I learned early on that I could put
zip codes are in like Akron. There's tons of zip codes.
Sure.
So, okay.
Well, in theory, you've got their full address on file.
Sure.
So, or at least an address when you started to see them. So I never tried city. Has anybody else tried that, city and state, as opposed to zip code? No. I mean, zip code's just easier. So
yeah, that makes sense.
But good question. My guess is it might have that level of intelligence, so to speak, but I don't know. So when you pull it up, I'm going to sort of give you a few screens about what you see. You basically, of course, you get a patient report. It's going to give you, there's more information up at the top. You can't quite see it. It looks all black there, but if you click on that, it actually will tell you the addresses that are on file in the system for that patient. So at least you can see where they've lived that's in the database. And of course, that might have different zip codes, but you've got their street addresses. So you do have some information there in the event that you're on that system, you don't have your file there for some reason with their address, you can actually get their address off of that if you needed to send them a letter or something. I did that once. That's how I discovered that. And then, of course, the main point of this, and I can't do a laser pointer here, I guess, on the screen, but the main point is that it will now show you that biggest column kind of halfway down. It says tramadol. It'll give you the medication. It gives you the dose. It also tells you how many pills are dispensed and for how many days. So, for example, in Ohio now, you're required, if you write a prescription for oxycodone, you have to write on the prescription blank the actual well, it wouldn't be F, that's probably all psychiatry, but the actual diagnosis code that you're prescribing it for, and you need to write the number of days supply on there. So if you gave them once a day pill and you wrote 30, you'd still have to write 30-day supply. That's another requirement. I don't believe they really require it for everything, but I just started doing it even for Ambien. My response, I'm just going to do it. They do want the diagnosis code. I think they didn't care if I gave them the number of days supply for antidepressant or a sleep medication. But to me, it just made sense. So that was the other piece you put on there, which goes into the database in the background. It's not something you can pull up. I've never seen a way to pull up the diagnosis on OARRS. And so that maybe that'll get added because now the pharmacies are clearly putting that into something, but I've not seen that. Speaking of which, this then shows you, see this as Walmart as an example, which pharmacy they went to, and then, of course, who the prescriber was. Mm-hmm. So I did have a couple of occasions where, only a couple actually, in all the years I was seeing workers' comp patients for about a decade, where I questioned a prescription, I did call the prescriber. It's nice because you can do it. Now, what you can't see on here is if you went down to the very bottom of the screen, it has a key and says, what are those abbreviations? Who are those doctors? And it gives an address and a phone number. So you could then reach to doctor. I could say, oh, Dr. Jones, I need to talk to Dr. Jones because there's something going on here. Or actually, one of the two times it was that the person had gotten an antidepressant from somebody else in the time. And I'm like, well, that doesn't make sense. I've been seeing the person for 2 years and they got an antidepressant somewhere else. It turned out it was a low dose, and I guessed correctly, but it turned out it was a low dose of amitriptyline, which can be for pain. So, but it was not a good interaction with the other antidepressants I had given, or any depressant I had given. So we had to have that discussion. So it does give you that tool. The other thing that I discovered, which I think is also important, is on occasion, I'm going to just say a pharmacy error. Let's say Mr. Jones, I just saw Mr. Jones, but he also saw, we lost our screen. He also saw, can you hear us?
Yeah,
Okay.
I think so.
They also saw Dr. Ammon, who gave pain medications that day. And they go and they hand all of the scripts together to the pharmacist. And I discovered on several occasions that they filled them all under my name. So they had me giving the antidepressant, but also 3 opiates, and believe me, I called the pharmacy about that one and said, hold on, I don't want my record saying I gave a bunch of opiates, because I don't ever give opiates.
Because you're right, this isn't just about the patients, it's looking at the doctors too.
I mean, I'm going to get to that, because you can look at reports on yourself as well.
Okay.
So to me, it's just logical to, if we're going to use it, I mean, it does take it's actually very fast now. And if others have any problems, let me know. But I found it's very quick. So you can go in really fast, pull it up. You're not really wasting much time. And, it does give you something to assertively discuss with a patient if he turns out they're doctor shopping. So I had my second occasion turned out to be a doctor shopping thing. The patient had magically gone to somebody at the Cleveland Clinic maybe 6 days before I saw him, and had gotten Xanax. And so we discussed it, and he said, well, no, I didn't get it. I said, well, did you go to the Cleveland Clinic? Well, yes, I went there for whatever he said. And I said, well, you got Xanax. He says, oh, maybe she gave you a prescription. I didn't get it. I said, no, it says you filled it at this pharmacy, So it gives you all the details. It won't show up if it didn't actually get filled at the pharmacy. So they went and picked it up. Now, did they actually put the pill in their mouth? I have no idea. Did they divert it or sell it? I have no idea. So all you know is whether they filled it and got it. Mostly that's what we want to know anyway. Short of a fleet of drones following them around to see if they took it or not. And Amazon's working on that. I think that'll happen in about 10 years. But
once they partner with Google.
Once they partner with, that's right. 1984 will be here. So here, I'm sorry, I should have done this. This is a little bit bigger blow up to give you a better sense of what shows up in terms of information. So again, you can see the patient, obviously. You can see the drug, the number of days supply, the pharmacy, and the address, and so forth. So, and then you can click on those and actually get some more details if you needed to call them the pharmacy for, like as I did in that couple of times that my in quotes prescriptions appeared to be opiates. So, again, I mentioned patient alerts. So these can show up, and obviously I've actually never had one show up on my workers' comp patients. Has anybody had one show up that wants to mention what it was? All right, silence is golden, so I guess not. So anyway, so that I've not seen it happen, but my understanding is that they can push that through if they suspected. Now, I'd rather them call me, quite frankly, but at least they could. And truthfully, since I had a relatively small practice and I called often probably the same 25 pharmacies for my 100 or so patients, I got to know a lot of the pharmacists by phone. So I would call, and it was nice. It comes very nice. We go, oh, yeah, is that for Mr. So-and-so? Yep, okay, same thing, yep, same thing. And that would be it. There wouldn't be the whole read back and all that business. So it actually was nice. We'd actually talk about something pleasant. How was your Thanksgiving? Or none of these people I ever met in person, but when you're a solo practitioner, there is some, even in my small practice, some sense of isolation. So getting to know your team is kind of nice, right? Kind of thing. So, but anyway, so then of course there ought to be, and there's a whole system here to correct errors. So let's say you pull it up and discover that for whatever reason you accidentally gave, let's not even put it that way. I'll use my handwriting. If my wonderful handwriting got translated into 40 milligrams of Prozac instead of 20, and I look at it and go, uh-oh, then I would be able to fix that. And the pharmacy would see that, and obviously I'd have to call the patient if they weren't sitting there with me. But I mean, so there is a way to go in and fix things. I'm not sure, if it's not fast enough, I'm not sure it helps, because I'm like workers' comp, they're probably not gonna refill the person's meds because of the cost. We have to be like, well, how are we going to solve this? And depending on the medicine, so if it's Prozac and it's a capsule, I can't tell them to cut it in half, for example. You know, if it's the only one that is a tablet is 60 milligrams, I can tell them, cut that in half. Let's go, you know, back. It was supposed to be 30, whatever. I didn't, as far as I'm aware, I never had that happen. The only time I know there was a misread error, which I don't know would have gotten caught on this, was a patient who came in and she complained that the Prozac was not helping her. And yet she was feeling, you know, for lack of better words, hormonal. So I said, well, did you happen to bring, she did actually thankfully bring the bottle, and instead of 10 milligrams of Prozac, which I always started low to be careful for side effects, it was Premarin, hormonal replacement.
Oh,
so not surprising she was having some effects of that. Hormones are pretty potent. So anyway, so I mean, those things can happen. And weirdly, the pharmacy didn't question it because it was actually the second month I had given the Prozac at 10 milligrams. So it's kind of like, I was a bit chagrined about that. That was closer to fully 10 years ago. And again, this wasn't in full. Actually, I'm not sure this was in play at all yet, but still would have been nice if the pharmacist had reached out to me.
Yeah.
My prescription pads have my phone number on it and all that. So they easily could have reached me. So, okay. So on this at the top is the error correction. Yeah, this is really small, isn't it? But basically there are tabs, no surprise, where you can get more information to drill down if you needed to on the pharmacy and things of that nature to learn. I've actually, again, never had to use this, but it is more of a tool. Anybody ever used this screen at all and gone through these tabs? I'm seeing head shakes. I think most people haven't. So maybe that's the value of me going through this, at least, is there really are more tabs there. And I'm sorry I didn't print my slides that I can't read it either. Let me see if I can read it. I can tell you what it says, and I can't. Yeah, so
Just getting right into it, thank you.
awesome. So, if one of you could do some liposuction while I'm reading this, that'd be great. So it does have pharmacy. It's got the error correction is what's highlighted in purple. That's what we were just talking about. It's got the prescription maintenance. I think that gives you like a graph of the medicine changes over time. It's got the pharmacy on the far right-hand corner, and honestly, I can't read the middle, the third thing at all. It's really strange. I use this snippet tool, and it didn't make everything. Yeah, maybe it is a new prescription.
I think.
You might be right. It's definitely something RX. I just can't read the rest. But it is only 3 digits, so you're probably right. Anyway, but at least there's more here than you know. I like this. So now when I pull up the patient profile, normally at the top is what I showed you. You can also see this component a little bit further down the page. And this is, you know, this is the old picture's worth 1,000 words, right? So what this shows you is the prescriptions that they've received. On the left-hand side are all the people that gave them prescriptions. So this person's been to a good number of doctors. That's why this is a good one to use. Fake patient, by the way, not a real patient. So if you look at that, you'll see I think it says narcotic and sedative and stimulant. So it's got the main classes. I don't think they include, like, Neurontin wouldn't fall in there. Things they added wouldn't fall in there. Sorry, we lost our screen again for a second here.
The person, so the graph that you showed really showed that the person was not interested in stimulants. There was like a little bit of sedatives and lots of.
So right. So those numbers, right. So the numbers, the higher number is bad, right? So the higher the number, the more they're getting of those substances, and then the width of the graph of the slice. So for example, 1, 2, 3, 4 lines down on the graph, you see the larger red bar has to do with a bigger dose. So it gives you a quick visual of what's going on with this person.
And how are the prescribers ordered? Is it like from most recent at the top to least to farthest away at the bottom?
I think it's.
Or is it just alphabetical?
No, I think that is accurate. I think the top is the most recent.
Okay.
And the bottom, so I think because you're trying to read.
So you get a picture over time.
You get a picture, exactly. Picture over time. And then the bottom part, that little smaller graph is actually then their morphine equivalent dosage. So you're getting to see over time in a quick glimpse So you can see there, not too surprising. Initially, there was a pretty stable, and then probably tolerance. It started to go up, and then of course there was probably a new law passed, and they started to drop the dose. And then of course the patient went without the opiates for a period of time, and then probably for some legitimate reason had an exacerbation, maybe a new injury. I'm thinking about my workers' comp patients, but it had a new injury, and then bam, somebody said, all right, you deserve more opiates. So, but again, I mean, it's a nice quick visual. And then the composite score up there in the middle is their risk of overdose death. That's a bad number, 790. So then, and I'll show you, I think I've got some statistics on that in terms of how that affects it. So here we go. This shows you the, I'm sorry, I said dose, I meant the days supply. So if you look at this, you'll see that large bar, that's a blow up of that same bar that I mentioned, was a 30-day supply, as opposed to they went to the emergency department. Looks like this person did that a lot. You saw a lot of small bars, and was handed one Percocet because he said he had tooth pain. And well, you know, that's the best one to complain to in the ER because they don't know anything about dentistry, and they just don't. And so it used to be they'd give them a 30-day supply or 90-day supply even sometimes. Now, I'm going to give you a pill, Mr. Jones. You better see your dentist tomorrow, right? So, or find a dentist tomorrow, which is probably more likely. Not easy to do, but the ER is no longer going to just start handing out opiates. And many ER doctors won't give you any, let alone one, but at least there's an opportunity to do that. So I think that's kind of nice. Okay, and then I mentioned the scores, and you were kind of commenting on those, and how many active prescriptions. You'll notice on that, let's go back for a second, you'll notice that in this case, at the present time, and you can see that kind of at the very top of the graph, it kind of went away. And like there's a period here, and this is past the bottom. So the person actually, the zeros mean they're not actually right now getting anything, but in theory, the concept is they have some of these drugs at home, and so they're going to keep that risk score up there because they don't want somebody inadvertently to come give them more medication, is my understanding of that. So, so you'll see at the bottom, like A says patients who use small amounts of medication with limited provider and pharmacy usage will have a lower score, right? So, i.e., less doctor shopping, or more assertive physicians, I suppose, who are saying no, we're not going to give you anything more, and then they, ultimately they're able to calculate a score which gets into the issue. Here we go, of unintentional overdose death, right? So that person with a 790 is pretty high. So right. So this is the odds ratio, right? So 141 times more likely for that guy. Actually, it's almost closer to 194 with a 790. And that's pretty high, right? I mean, you should be more worried about that person than the person who's got a 190 as opposed to a 790, right? So you can say, okay, I'm not too worried about that individual from that. And believe me, I had some workers' comp patients whose scores were in that 900 to 999 range, and I was always concerned. I'm like, do I really want to give you anything? Probably not. And of course, there's a lot of issues right now about benzodiazepines plus opiates. And many individuals with opiate use disorders seem to, even more than others, want benzodiazepines, whatever that's about, probably some kind of synergistic effect that those of us who don't take both of those things don't know. But there's higher risk of death. So prescribers see that literature constantly, I think. And then I mentioned the bottom of that graph was the morphine equivalent dose. So the brain basically sees morphine, and just like the brain only burns glucose, so all the other stuff, fat, all that stuff we take in, brain doesn't care about it. The body's job is to turn it into glucose, and then the brain can actually use that to burn energy. So just as for opiates, it sees morphine, and morphine is the naturally occurring opiate as opposed to the man-made opioids. And so you see here that if these numbers get to above 650, there's a bunch of stuff we should be looking at, right? And again, most of us aren't giving out that level of opiates because we're not pain specialists. But again, there may be alerts that come from this, just like we often, I'm sure you all as well, if you, maybe not Amy with pediatrics, but in the geriatric population, you'll start getting these Beers criteria reports from the company saying, hey,
Yeah.
you've got.
Andrew's talked about this before.
Okay, there you go.
Yeah.
So you've got people on too many things. They're older. Maybe this dose is too high. That kind of thing. So other things come into play. But in this case, OARRS was created more about controlled substances and particularly opiates. You see, suddenly you go from consider an naloxone prescription to a whole bunch of stuff if you hit a certain dose. And it is not hard to hit the 90 morphine equivalent dose. And my workers' comp patients, pretty good number of them were at least above 60. So they're already above that middle range there of 50. And some of them were 120 or more in that. So
But it is nice that they offer the guidance that really is about having different levels of conversations with your patients,
Yes.
having different levels of conversations with the rest of the team.
right.
No, it's nice to have the guidance out there and that it's listed as guidance. So if you already know these things with your patient, then it's not like you have to do these every time because you have an established relationship.
Right, exactly. And it really is about safety. I mean, so it's helpful for patient safety, even if they're not trying to be safe or maybe they're even purposely trying to not be safe. And I think, quite frankly, it's prescriber safety, right? So we're able to go, wait, hold on, this is not what he told me or she told me when we did the evaluation. And here I am doing all this educational stuff before we choose a medication. And it turns out, based on this, I shouldn't have even talked about that because we're not going there kind of thing. So you can get technical assistance and support from OARRS, and you can do that, through the web as well as on the phone. And I've not had the need to do that, thankfully. The OARRS report, just like everything else we all use nowadays, does periodically trigger you to update your password. So it's not like you do one password and it stays forever. It's a pretty good long time period, though. It's at least a year in between when I've been prompted to change the password. So it's not terribly frequent, but it certainly does change. They do prompt you up to a point where if you don't change it, then you'll be forced to change it. So you can't get into it otherwise, like many things we use. I should say, although they don't have screenshots on this, you can actually look at your personal prescribing habits compared in aggregate to other prescribers. So you can get a sense of, am I overusing sedative hypnotics for sleep compared to my supposed peers looking at this. Now, granted, your patient population may skew that, so you can't. So a palliative care physician is going to probably have much higher scores, than I would as a psychiatrist. As a good comparison, I'm giving out no opiates. He or she is maybe giving out huge numbers of opiates, but they're not too worried about overdose death because the person's kind of on their deathbed in major pain anyway, right? So less of an issue. But for most of us that are treating a larger range of population, you're more likely to get a good comparison. Say, I didn't realize I was, using so much tramadol. I wouldn't, but I mean, somebody could say that when my peers, it says they're barely using this stuff. So what's that about? So it doesn't tell you, bad prescriber or anything like that, but it gives you a sense of kind of where you're at with your peers.
Oh, that's interesting.
And so, I mean, that's just another tool. I couldn't find any good screenshots on that, and I tried to actually talk to people at the Department of Health. I don't know what that's about and why they don't have their own PowerPoint. So I had to create this with the snippets. I haven't figured out why. It's been around a while. I think it was April 1st of 2014, I think is about when they made this mandatory. So it's been quite a while. I mean, it's been almost 6 years since they made it mandatory. So any of us who've been prescribing that long, and I suspect most of us have, we've had to use it. So
it is interesting that there's not been some kind of larger public presentation about.
I've never
how to
seen
use
one
it.
actually. Right.
Yeah, that's interesting.